I should turn off my phone because my father is 89 years old and he's getting his grocery delivery today. So um, probably call me because I did the delivery and they probably forgot something. So anyway, um, welcome to today's talk. It's good to see. I see some faces I haven't seen for a while. Michael, Lexi, welcome to the talk. It's National Public Health Week. So some of you students know that we were supposed to be doing some tabling events around hand washing, around some other things. Unfortunately, we weren't able to do that, but we wanted to do something for National Public Health Week. And of course, what is everyone talking about? Everyone's talking about COVID-19, the coronavirus. So I was really lucky that we have some great colleagues here at University of Michigan Flint and some great students. So we were able to throw together a panel relatively quickly of experts on various topics. So without further ado, I'm going to begin. We're going to be speaking in the same order as listed on the brochure that we sent out. And those of you who know me, I'm kind of a casual type of person, so it's going to be kind of casual. And I'll introduce myself, and then I'll introduce the next speaker, and the speakers will introduce each other as we go down the line. I sent you guys some bios just in case. And we already have some questions that students and other people have sent in that I've sent out to the panelists. But we have about a half hour at the end that we can have a question and answer session or some kind of discussion. So I'm the first speaker. For those of you who don't know me, I think I recognize everybody on the call, but just in case, my name is Michelle Sally. I am a faculty member in the Public Health and Health Sciences Department. I'm also the program coordinator for the public health programs. I got my PhD in epidemiology from the University of Buffalo in New York in 2016, not that long ago. I started out in infectious disease epi, and I changed to nutritional epi, and lo and behold, I should have stayed in infectious. So here I am. I'm going to speak a little bit today about, I'm trying to see if I could get my PowerPoint to advance. I think I can. Yeah. I'm going to speak a little bit today about viral transmission and modeling, because we hear a lot about this, like transmitted, and this virus is being modeled, and this is what the model says, yada, yada, yada. And a lot of those words are kind of vague to some of us, right, if you haven't studied it. Just to let you know, my talk is pretty generic. I'm not really talking about per se always the coronavirus, but that being said, we have no reason to believe that the coronavirus actually behaves a lot differently than any other virus, right? It might be more virulent, it might be more transmissible, but it doesn't seem to behave really terribly different than any other virus. So that's why this is pretty generic. So the first thing I want to talk about is, what is viral infection, right? So viral infection is just the entry and development or multiplication of a virus in the body of a person or an animal. And truth be told, even plants can have viruses, right? There are plant viruses. So any living thing, right? It doesn't mean that you have an infectious disease because it's in your body, right? The infectious disease comes when the clinical symptoms manifest themselves, right? So you can have subclinical or clinical infection, and that's important in coronavirus because there's a lot of, well, we think there's a lot of subclinical infection out there. When we say clinical infection, it means that you're showing signs and symptoms, right? You have chills, rash, fever, sore throat, or whatever that particular disease does to you, right? And subclinical means that you really don't feel the effects. You may have a little, cough or something, but you really don't have a lot of effects of that disease. And in this disease that we're looking at recently, seems to be the case in a lot of people, right? So what are some characteristics of infectious agents? So here, when I talk about infectious agents, I'm really talking about the virus, right? That's the infectious agents. One of the characteristics is its infectivity. So what's its capacity for transmission? How well does it transmit? Certain viruses transmit more quickly than others, right? Another characteristic of an infectious agent is the infectious dose. So what that means is how many particles of that virus have to be in your body in order for you to actually develop that disease. So if you have one viral particle, typically you're not going to get sick. Your body will be able to fight that off. But there's a certain number, and that depends on the disease. There's a certain number of viral particles that you need to have in your body to overwhelm your immune defenses. And that also depends on how good your immune defenses are. Then we talk about the pathogenicity of a virus. So that's how well and how is it able to show symptoms, this virus, right? So how does it cause symptoms? And usually we estimate this by looking at clinical versus subclinical infection, right? And then the last but not least is its virulence, so its capacity to really cause severe disease. And typically epidemiologists measure that by looking at the case fatality. So the case fatality, for those of you who took my class, hopefully you know this, is the proportion of people who die from a disease that over all those people who had the disease. So of all those people who have the disease, what's the proportion that died, right? So this is always a percentage, right? It can never be more than 100 because you can have more than 100% of people dying. So those are some of the characteristics of infectious agents. We talk about transmission, and this is particular to the coronavirus. There are a lot of different ways to transmit diseases, but not all diseases transmit in all those ways. And in the interest of time, I just put the ones that we believe are the main routes for transmission of coronavirus. Again, everything that I'm saying and probably everything that everyone who follows me says is subject to change because this is new, things are changing, things are evolving. But if it is like any other respiratory illness, droplet transmission happens. So that means that you have respiratory droplets. It could be from coughing, sneezing, or even like a little bit of spittle when you talk, right? And it may not be big drops that you can see. And it could be from close proximity. So you're close to somebody and you can actually get those droplets on you. Or it could be indirect. So that means somebody's respiratory fluids got on an object or a body part and you touched it and then touched your eyes or your nose or your mouth, right? So this could be doorknobs, it could be shaking hands, it could be these little droplets. So those are the ways that we think coronavirus is transmitted, right? A little bit about dynamics of disease. When can this be transmitted, the coronavirus? Well, at the beginning of time, you're susceptible. You, as in the generic big U, you're susceptible to a disease. So we think that everyone is susceptible to this disease. No, it's a new disease, so we don't really know if anybody has any kind of immunities, but it appears that everyone's susceptible to it, right? So when you're susceptible and you don't have the disease in you, of course, you can't transmit it. But we think that from the time that you're infected, so that means the time you have that disease in your body, to the time your symptoms resolve, you can transmit this virus, right? The person who has it. Between the time of infection, we have this incubation period. So this is the time the virus is working in your body till the time symptoms actually appear. It's called the incubation period. And then you have a symptomatic period where you have symptoms, and then you have some resolution of symptoms. And this is generic for all diseases. After your resolution of your symptoms, you can really have 4 different outcomes. One is you become immune, right? That's like I had the chicken pox, I'm immune to them. You could become a carrier, so you can carry the disease in your body, but still be able to actually infect other people. You could die, or you could just be totally recovered, neither a carrier, neither immune, right? Those are the 4 possibilities. We think that coronavirus is transmitted in this period of time between infection and resolution of symptoms. So I just talked about immunity. You can become immune. What does that mean? It means that your body can resist this virus. It can fight it off. It's kind of protected against it. And you can have active immunity. So that's because you've actually been exposed to the disease or you've been vaccinated from the disease, right? Your body, your immune system has learned to fight this disease off. Or it could be passive. So it can be conferred by antibodies produced in another host. So a lot of times this happens from mother to child when they're first born. And I have the question mark here on plasma because they're doing trials right now to look and see if plasma from people who have recovered will confer maybe not immunity, but some kind of therapeutic help to people who actually have the disease. So there's a question mark there because that's still being studied, right? And so the big part of immunity is this concept of herd immunity. And I know when we talk about anti-vaxxers, we talk about that a lot. It's immunity at the population level. So when a certain percentage of your population is immune to a disease, whether because they've been vaccinated or because they had the disease, then the majority of the population or the whole population is protected. So you may see one or two instances of sickness, but overall the whole population can be protected. And the number that needs to be immune really depends on the disease, right? So that's something about transmission, but we're talking about modeling. And I know in my class, we're doing modeling, those of you in my class, and I asked people to build a model and I got probably 10 emails that said, what do you mean a model? So first of all, what exactly is a model, right? It's just your representation or a simulation of something. And in this case of how the disease either develops or how it's gonna happen. So we either put numbers, we can put pictures to it. Basically a model is just that, just something that we can actually visualize what's gonna happen or what's happening right now, right? Here's a model that Brenda just sent me today of the coronavirus in Michigan from the websites on the slide. If you want to cut and paste that. And it's one way of modeling things is through these graphs, right? So I don't know if you can see my pointer, but right now, this is all the beds needed would be here. ICU beds, this is what they're projecting, right? To happen. And that depends on what happens, right? That depends, are we socially distancing? Can we find a vaccine or whatever over a period of time? We probably won't find one by the time this model's up. But I'm going to show you some more simple models that we use in infectious epidemiology or any infectious disease, because these are kind of complicated to make. There's a lot of variables that go into it. So this is a very simple graphical model of transmission probability. So we have an infectious host, and the inputs into this is the virus, the characteristics of the virus, and contacts that we have with other people. And that will determine whether this susceptible host over here on the right gets infected, right? And we call this transmission probability. And all that means is the proportion of times transmission occurs per contact event, right? It varies according, it's the, proportion of times transmission occurs, right, per contact. And it varies according to the microbe in question. So if it's very infectious or it's very virulent, that can change its transmission probability. The nature of contacts, is it discrete? Is it just one contact or is it a continuous contact? If you just meet someone in the street, you probably have less probability of getting the disease than if you live with somebody who has the disease and you're seeing them continually. Is it direct contact? Like, did you kiss the guy with the disease? Or is it indirect? Did you just touch a doorknob and then you were able to wash your hands, right? It also depends on the characteristics of the infectious disease, the virus, or the host. So if you have a low immune system, for example, right? So this is an equation. It's another way of modeling, and it's a simple expression, N times P, and P is the transmission probability. So the probability that one time will result in infection times the number of contacts you actually have with an infectious host, right? So if I meet 10 infectious hosts, I'm going to be 10 times, I'll have 10 times more probability of being infected than if I just meet one. It's very simplistic, right? And there are some assumptions that aren't necessarily true. One is that an exposure occurs always in discrete contacts, not continuous, right? It also assumes that each contact introduces the same risk of transmission. And we know that's not true, right? It depends how close we get. It depends what we're doing with the person, so on and so forth. It also assumes that each contact is independent of your other contacts. So in other words, you see each individual once, one at a time, right? It's not like the whole family coming over. And it doesn't account for anyone being immune or saturation. So saturation would be like a lot of that population is already has the disease or is immune from the disease. So this is another type of modeling. Okay, and then the ever known number that everyone makes fun of the way I say it, but yes, I'm from New York, everyone. The reproductive number R naught, not, I don't know how to say it. So what is R naught? What's the public health significance of R naught? And why is it important in this novel coronavirus pandemic, right? First of all, what is R naught? It's a numerical model, right? It's a way of showing things using numbers. You can see this graphic here. The little dot in yellow is the guy who has the disease, the infectious person, right? The little black dots are people who don't end up getting the disease, and the little red dots are people who do end up getting the disease from the little yellow guy, right? So because this one person infected 3 people, so the 3 red dots, we say that R naught equals 3. So the word definition is it's the expected number of new infectious hosts that one host will produce. So if I get sick, how many people am I going to get sick that are going to be able to go on and infect others, right? And it's assumed that this is happening during the infectious period, of course, and that the entire population is susceptible to the disease, right? So it allows us to compare diseases. So I think you've probably already heard the flu's R naught is 1 point something and coronavirus is 2.3 or whatever they're estimating it to be today, right? And so it's only for a specific pathogen at a specific period of time in a specific population. So each one has a different R naught. So some assumptions of R naught are that all contacts are susceptible. So we're assuming that nobody is immune to the disease, right? We also assume that every person who has the infection is equally infectious. So I'm just as infectious as Stephen, as Dr. L, as anybody else on this call if I get that disease. It also assumes that there's a homogeneous mixing of the population, right? We're all moving around, right? And everyone has the same likelihood of coming in contact with everyone, which we know isn't true too. It's an assumption because I know Bubba, I may come in contact with him, but there may be somebody on this call, Monica, that I don't know, and I probably don't have a big probability of coming in contact with her. But these are the things we do to model because we have to assume something in order to create a model. So these are 3 different models, right? And oops, I do that all the time. This first model is the model that we're kind of in right now, right? And so they're saying that coronavirus is the R naught right now. They're thinking is about 2.3 to 2.5. It changes every day, right? But here I just put 3 red dots in there because I didn't want to make half of a sick person. But at any rate, when your R naught is more than 1, you have to start thinking about whether you have an epidemic or not, because that means you're going to have more people sick. For every person you have, it's going to keep multiplying. So when they talk about this exponential growth, where you keep having this curve that goes up, that's when you have an R naught of more than 1. So more than this one little yellow guy can infect 3 or 2 or 3 or 4 or 5 more people. When the R naught is 1, it means that your disease is endemic. And endemic means it's the regular amount of disease that you're used to seeing in the population. So coronavirus, the endemic amount is 0. So we don't have any endemic. So right now we're at this epidemic stage. And once your R naught gets down to less than 1, so that means that if I get infected, I only infect half of a person, or I should say for every 2 people who get infected, 1 ends up sick. Then you can say that you're on your way to eradication. Not that it's eradicated, but you're on your way there. So that's what those question marks mean. You're on your way to those things. So some fun facts about R naught, because I'm kind of a nerd, is it is dependent on contact rate. So if an infected person comes into contact with a lot of people, the disease is gonna spread more quickly, right? So if I happen to be a fun-loving person, I go out dancing and stuff, I can infect people more than if I'm a homebody and stay in my house and read a book, right? It's also dependent upon how long the infectious period is. And this is the coronavirus, because we know that, well, we think that the infectious period is about, well, the incubation period is about 14 days. And we can see that people stay ill for a pretty long amount of, substantial amount of time, if you look at how many people have recovered. So during all that time, they're able to transmit the disease. So that's what I talked about before, the incubation period and the symptomatic period, they're still transmitting this disease, right? And if the transmission probability is high per contact, of course you have a higher R naught. So it's an average of everybody, right? It's not just one person. That's not how they measure it with one person. They actually look at everyone. And even if your R naught is less than 1, you can still have a cluster. So one person can still make a bunch of people sick, but that probably won't result in an ongoing outbreak, right? Those are some fun facts. So this is an example, right? And so this is important because so far, I mean, I guess some are now, but at the beginning of February, none of the population was immune to coronavirus. So this is an example, actually, more like influenza. So about 45% of the United States get their flu shot. So let's say, half of the population is immune. And I'm making those numbers up. But if half of the population is immune and the R naught is 3, then R, which is actually the people who actually get infected, equals 3 times 0.5, which is 50% of the population. So that brings it down to 1.5, right? So it means that each case of this disease only produce 1.5 secondary cases. So we have that in influenza. We have that immunity to fight these things, but we don't have that with coronavirus. I'm almost done. So what would you have to do to R naught to decrease an infectious agent in a population? I'm not going to make you answer. I'm going to tell you the answer. You have to make R naught less than 1, right? And keep it that way, right? You can't let it go less than 1 and then let it go back up. And how do we do this, right? We're doing this, so the black on this slide is what we can do, and the red is what right now we can't do for the coronavirus, right? We can reduce the contact rates. We can do physical or social distancing. We can work remotely so that we don't have that contact rate, right? We can reduce the probability of transmission per contact, use of PPEs, hand washing, hand sanitizer, doing all these things. These are things we can do. Can we reduce the duration of the infection period? Not right now, right? We don't have those things. There are some medications in clinical trials, but right now, none of them have been proven to reduce the duration. And we can increase immunity. We could do this through vaccination, but we don't have a vaccination yet. So basically, what we're seeing is we can only do these top things right now. Okay, so that was my quick transmission and modeling presentation. Going to be trying to do a whole class in it soon, but just stay tuned. I did have some questions from students. One person asked me if a patient tests positive for COVID-19 and goes into quarantine or social isolation, how long should they be in quarantine and what signs should they look for that it's safe for them to resume limited social interaction? So this keeps changing, right? Keep finding out new things. We keep changing. I think right now what they're saying is you should be symptom-free for 7 days, but it was 3 days before, and it could be different today. I didn't look it up today. So it keeps changing. My advice to somebody like that would be to check with their medical professional, right? Because every day that changes. Someone wants to know, how will we know when it's safe to go back to going out and having a normal life, and how can we make sure the disease won't come back as bad as when we do it, right? It's just as bad when we do it. I think the CDC is going to have to tell us, or our governor will tell us when they think it's safe to go back. Hopefully they'll be listening to healthcare professionals. That's when that first model, when we're on that downward slope and our R naught is less than 1, it'll be safer to go back out. But that's with caveats that that we have a lot of testing and we can find people early in their disease and we can trace their contacts, and there may be some self-isolation or even quarantine if people get the disease on a smaller basis, not a total lockdown. And hopefully we'll be able to get to that soon. I can't tell you when. Is there any current news on the success of research of medication or vaccine for COVID-19? Vaccines being working on. I know they're in phase 1 of their clinical trials. Clinical trials take about 12 months minimum to actually go through. So that's going to take a while for us to go through them. Have they been successful? I haven't heard whether they've actually been able to tell that yet. There are some treatments in, and I'm looking at, because I can't always pronounce the names of these things. There are some treatments in clinical trials. Everybody's heard about hydroxychloroquine or chloroquine. The evidence is still out, right? I think some people are highly convinced that it works. The evidence is out. We don't know yet if it's working. We don't know. There are other medications, and I think there's about 20 medications right now in the clinical trials all over the world, and some are in more than one clinical trial. But so far, we haven't found, evidence that any of them actually work yet. So it's still new, and we'll see. And so I'm going to give you an opportunity to ask questions later, but for now I'm going to introduce my next speaker, who is Dr. Amini. Dr. Amini has a PhD, MD, and an MPH. We've got a lot of letters after his name, and he's assistant professor also in public health and health sciences. He's authored several book chapters and peer-reviewed journal articles. I'm going to stop sharing so you can get yours up, right? View options. How do I stop sharing? I'm sorry. I have to figure this out. Are you able to share, Ezra?
We can see Reza's.
Okay, I can. Maybe I just need to stop mine. I'm sorry, people. So I'll read it and then I'll try to do that. Sorry. Dr. Amini has authored several book chapters and peer-reviewed journal articles in public health, disability, and aging. Prior to his PhD studies, he practiced as a general practitioner for more than 15 years in Iran. So that must be interesting for him to think about what's going on over there. He also co-founded a clinic to treat patients with substance abuse disorders, and he held the position of Director of Research Division and Medical Research Center in Iran for over 10 years. And he also teaches a lot of our healthcare administration courses and co-facilitates the virtual hangouts with me on Tuesday nights. So I'm gonna let you go ahead and say your piece.
Okay. Good afternoon, everyone. Can you hear me?
Yes.
Okay. And could you please mute your microphone if you're not talking or you don't have any question? So I'm going to talk about very briefly about COVID-19 and older adults. As Dr. Sally said, it's an ongoing situation and we are learning as we go through. But I'm going to share with you some new findings and something about physical health, mental health, and social health that can affect older adults. So when the virus enters your body, it goes to the back of your throat and travels to the lung. That's the first entry of the virus. And it can also enter the GI system, your intestine, and start the infection there. So some people may start having diarrhea or some GI upset, gastrointestinal upset symptoms. But many people start feeling shortness of breath, fever, and cough, dry cough. What happens in the blood? So, and why older adults are more susceptible to the disease and the side effect of the disease. So when the virus starts producing more virus in the blood and in the tissue, there are some changes in the blood chemistry. The number of blood cells, the number of lymphocytes drops significantly. It happens in every infection, especially in viral infections. But in this COVID-19 infection, it is very significant. The lymphocytes are responsible to fight against any infection. So when the number of lymphocytes drops, the person or the patient is more susceptible to any kind of infection, including bacterial infection. So it can affect, it can increase the risk of pneumonia with some other bacteria and germs than COVID-19. And it also increases the level of angiotensin II in the blood. And we know that angiotensin II is responsible to increase blood pressure. So people with hypertension, they experience higher level of blood pressure, and also people with diabetes mellitus. These two diseases are very common among older adults. So it can increase risk of hypertension, and you can say it can increases subsequently the risk of myocardial infarction or stroke or damages to kidney and liver.
Excuse me, Dr. Amini.
Yes.
Initially, we could see your presentation, and at this time, we can only see you. So in case you are meaning to share a presentation, just know that we cannot see it at this time.
You don't see it? I'm sorry.
No, that's
Thank
okay.
you for bringing it up to my attention. Let me see. Can you see it now?
Yes, thank you.
Okay. Yeah, thank you. So, the risk of myocardial damages can be increased by the virus, especially in older adults. So the virus can travel to the heart and affect the heart tissue, and also liver and kidneys. So the mortality, because of all these situations, the mortality rate among older adults is much higher than the younger adults. Another thing is about the anti-blood pressure medicines. These medicines can increase the number of receptors that we call ACE2 on the cells. And these receptors are the touch point of the virus, that the virus can insert and inject the RNA into the cell. So the anti-hypertension drugs can increase the number of receptors on cells, and the virus has more touch points on the cells to enter the RNA into the cells. So it can increase the risk of severe infection among those people. So it can increase the risk of mortality as well. And comorbidity and frailty are the other side effects. So it can be a trigger of starting a cascade of losing physical function after hospitalization. We see that a lot among older adults. They come back after hospitalization, they recover, but they lose their physical function significantly. And that can increase the risk of falling or other frailty problems. So we talk about routine or common, let's say, symptoms: dry cough, fever, respiratory distress. But among older adults, we need to remember that the pathway of developing fever can be dysfunctional. So what does that mean? It means many of the older adults can be contaminated with a virus, but they don't develop fever. So it's very important to remember that if we have a loved one and we see dry cough, respiratory distress, but there is no fever, that can be a symptom of coronavirus. And the other thing is delirium, confusion. With any kind of infection, we can see the confusion or delirium in older adults. It's very important to consider that as well. So how about mental health? This is a very stressful situation. And on the news, we see that 8 out of 10 deaths are among people 65 years old or above that age. So it's very stressful for them because of the mortality rate and the morbidity and long-term effect after the contamination. Financial problems. We know that there is a donut hole in the Medicaid, Medicare Part D. So when they use more medication, they will reach at the point that they need to spend out of pocket for their medication. That can affect the financial situation of older adults. It's a very stressful situation. We talk about social distancing all the time, and it can increase risk of isolation and loneliness, and they again increase the risk of stress and depression, suicidal thoughts among older adults. And all of these are strongly and significantly correlated with each other: isolation, depression, delirium, and cognitive function. Stress can increase risk of depression and suicidal thoughts, and the depression can increase risk of cognitive impairment or dementia. So it's very important to help them to get through this situation. How we can support them? The first thing is educate yourself, then talk to your grandparents or your parents if they are older. So talk to them, but do not scare them. Just educate them what is the situation and how they can prevent the disease. And the lack of mobility can render physical and mental health problems. You can start dancing with them or helping them to learn Tai Chi or any kind of physical activity can be helpful. And keep them away from people who are sick or at risk of contamination. That's very important. And provide them the supplies, groceries, and medications. It's very important to have their medication available at this situation. And that reduce the risk of contact and trips to the stores and contamination of the disease. Clean and disinfect the surfaces that you touch, and wear a mask when you visit them. Wash your hands before visiting your loved ones, and change your clothes if you are going, you shop for them. If you go to the grocery store and you want to bring something them, I would suggest you take them to your home, change your clothes, wash your hands, wear a mask, and take those disinfected or discontaminated items to their home. And call the healthcare provider if you see any unusual sign or symptom. Remember that they may not develop fever. Again, I'm emphasizing on this. And coping with the stress, some methods, having hope, giving them hope, that this is a transitional situation and contemporary, and we will go back to normal. Breaks, have some breaks from the news and have physical activity with them, and social contact with intimate people is very important. Try to have some contacts with them. You can use telephone, you can use the new technology like FaceTime, WhatsApp, or any kind of technology you can use. I know many of the senior adults, they are not comfortable to use the new technology. You can go to their house and keep the social distancing, and or if you think you don't, you should keep away from them if there is more risk of contamination. You can visit them from outdoor and have the social contact in that way. So that's my presentation. I would be happy to answer your questions after uh, the after the last presenters. And let me see how I can stop sharing.
You want me to introduce Stephen meanwhile?
I can introduce Stephen.
Okay.
Stephen has a BSN, and he's right now in the MPH program, Healthcare Administration, and he is a nurse at McFarland, am I right? Hospital in ICU, and he got admitted to medical school starting in fall 2020. Congratulations. And I think, Stephen, you can go ahead and.
All right. Thank you, Dr. Amini. Yes, I work at the McLaren ICU here in Flint. So there's the three hospitals. There's McLaren, Hurley, and Genesis for those that are a little less familiar. So I'm just going to kind of talk a little bit about what it's like being a nurse in the intensive care unit at the ICU during this pandemic. So not too long after the stay-at-home orders were in, we started getting a lot more of the patients, and my ICU actually got converted into one of the COVID ICUs. So there's still a couple units. There might be one left now that takes non-COVID patients to try to decrease the risk of contaminating other people. But ours was the first one to get converted to it. So I'm going to show you guys some pictures after I give a little description of what it's like. About some of the things we see there. It's easy when you're looking at numbers and statistics to kind of forget the human side of what this means. And even some people are saying, oh, we've only had a few hundred deaths or whatnot. When you actually get to see these people on a regular basis, it kind of brings to mind just how bad it is and how sick some of these people get. So typically what happens, the sickest of the sick come to our unit at our hospital.
Live webinar on COVID.
They're usually intubated by the time they get to us, if not.
It's a series of different presenters talking about different.
Oh, I think someone iPhone there. If you could mute your mic.
This is a nurse in the ICU. He's
Guys, can you mute your mic?
There was someone else who talks about that.
I just muted him. Go ahead.
Okay. Thank you. All right, so they're intubated down in the emergency department or when they come up to us. We were worried about early concerns about the COVID potentially aerosolizing. So for hospital terms, we have two kind of airborne precautions. There's the droplet, which usually a regular surgical mask will cover you. The droplets only travel, I believe, 3 to 6 feet or so. It's like coughs, sneezes. And then there's what we call airborne, which is aerosolized into the air, and it travels much farther on smaller particles. So basically our whole unit is airborne. We're required to wear N95 masks or capper systems, which are basically create an airflow inside of your helmet and push it out. These patients have an extremely difficult time breathing. It's not necessarily that we see them like the labored breathing, like with asthma, but their oxygen levels go down. We have them on the ventilators and we put them to the highest setting and their oxygen's still going down. So what we found at least helps delay the process is we have to put them in a position called prone, which is on their stomach. A lot of these patients, we have to use a special bed that does that for them. So I'm going to share my screen here and show you what that looks like. All right, can you guys see my screen okay? Okay.
Yes,
so
Stephen.
Thank you. This is called a rotoprone bed. You put them in here and then you lock in all of these cushions on top of them. And then you use the bed to flip them up on their stomach here. So this is a picture of them on their underside. If it'll load. And this basically helps their airways expand further. The backside of the lungs get some additional airflow to them. And I'm going to stop sharing for a second. My apologies. There we go. Okay, so this is what they look like on the underside. They've got this little helmet thing that they put on. We have to tape their tubes specially in, and they're at a huge risk for skin breakdown. Usually we'll paralyze them as well so they can't move their muscles, and then we'll heavily sedate them. With a lot of these patients, even the slightest cough can make their oxygen levels go down. I had one patient the other day that when they turned them back on their back, they went down to their oxygen level in their blood was 12%, and it took them 20 minutes just to get back up to 30%. So we basically couldn't touch them or move them at all at that point. And then a lot of these patients are having kidney problems. And this down here is a CRT machine. So we hook that up to them and it basically does the work of their kidney for them. These patients are sick enough that it usually requires just one nurse to take care of them at a time. You can't use, for safety reasons, we don't want to use too many. So we've got all that. You've got the rotoprone bed. A lot of times you have the CRT machine. And then the next thing that we have is all of our drips. You see here, there's about 6, 7 pumps here. We can easily have that many different medications running through their IVs at one time. Usually like 1 or 2 will be sedatives, painkillers. Another one will be perhaps for blood pressure. If they're diabetic, which a lot of them are, we'll be giving them insulin and the like. And then here's a picture of a ventilator. Not everyone works in a hospital or has seen one. One's fairly close to the ones we use. This medication is called propofol. We'll use this one as a sedative a lot. It kind of looks like milk. One of the issues we've been running into too, potentially, especially as this goes longer, is we are running out a lot of these medications because we're using them at such high rates and for longer periods of time than we're used to. And then this is just kind of a picture. This is what it's like for these patients sitting here. Fortunately, they're not typically with it enough to realize what's going on, but they have all these different devices and that we have to manage and look over. So one of the hardest things for family members is we don't allow anybody to come up to our unit. And even if they die, what we're doing right now is you have to put on a mask. You can come up to the unit, usually just one person, and you have to stare at your family member through a window. And that's just devastating for a lot of people because it's like when someone passes, you want to go in there, you want to see them and be with them one last time, and you just can't. Some of these patients, before they're intubated, they'll FaceTime their loved ones and at least say goodbye just in case something happens. We get a lot of phone calls to the units, and it's really hard not being able to be there for a lot of people. It's kind of every culture is different. You've got different people, how they bond with their family members. But one thing I've seen in common is that desire for people to at least be present with their family. And universally, you just can't do that anymore with everything going on and the potential risk. There's even one guy right now that has a sign up. He's pretty young. And he says, "Please don't give up on me." So remember, each one of those numbers is someone's loved one, someone that you could potentially be with and care about. And they're having to fight this battle alone inside of the hospitals. We actually lost one of our coworkers on the 4th to COVID. He's only in his 50s. So it can affect us healthcare workers too. With that, I will introduce, I don't really have any additional stuff to share at this moment. We'll save questions for the end. So let me introduce Peggy Kahn as our next speaker. She is one of our professors of political science. She was given the David M. French Distinguished Scholar Award for excellence. She earned her master's and her PhD in political science at the University of California, Berkeley. She teaches several different courses in our political science department and conducts research on women's employment, work-family dilemmas, low-income families' access to public services and benefits, as well as low-income families and economic security. So let's give her our attention now. Thank you, Peggy.
Wow. Are you able to see the slides?
Yes, we are.
Yes.
I can't see them right now. I guess I'll go blind. Do you know what control I should push so that I can see the slides?
I believe it's at the top right-hand corner on your screen. There should be, and I'm trying to get there, but my screen's doing.
Is it resume share or more?
No, it should be a screen that says split screen.
Hmm. Well, why don't I go blind then, as it were? And
Okay.
maybe,
Would you like me to put your slides up and then you're not blind? You can still see them.
sure, that means I should unshare my screen.
Yeah, and I'll get your slides up.
Okay,
I have
thank
to
you.
just find them here real quick. Sorry about that, guys. Let me get them. Maybe something to me. I had them before and then we closed them down and now, okay, I got them. Just open them up here and I will share my screen in a second. Let's take 1 second to open them up. Let's get a slideshow. Slideshow. And you can just tell me when you want to go to the next screen.
Right, I'm not seeing it.
Yeah, well, it's going to take 1 second. It's still opening. Sorry.
No, that's fine.
Okay. Okay, you should see them now.
Yes, thank you.
Okay, no problem.
So I would like to say a little bit about who has coverage, insurance coverage, or other kinds of access for healthcare given the COVID-19 pandemic in which we find ourselves. Next slide.
Sorry. It should be going. Technical difficulties, this one, right?
So we have an extremely fragmented, uncoordinated, complex and not universal healthcare system in normal times. And on the whole, we have to navigate and somewhat modify this system in this crisis. So in normal times, about 60% of Americans under 65 have had insurance coverage and real access through their employers, though faced with premiums, deductibles, and co-insurance. So employer-linked healthcare. Others buy private insurance through the Affordable Care Act exchanges or marketplaces, often with federal subsidies and some other things called cost-sharing reductions. Other members of the population have Medicaid. As everyone on this call probably knows, Medicaid is a program for low-income households. Traditional Medicaid required people to fit into certain pretty narrow categories and be poor and have limited assets and have residency of their state and have certain immigration status. You probably know that the Affordable Care Act allowed states to expand Medicaid, mainly dropping these categorical requirements and allowing low-income, able-bodied adults below 138% of the poverty line to be covered by public Medicaid insurance. Medicare covers most adults over 65 and some with certain disabilities. Some people qualify for both Medicare and Medicaid. Medicare involves also some co-payments. And then I want to make the point that about 28 million people, over 10% of the population, were uninsured in 2018. This means they had no insurance, neither private nor public. So this is the baseline from which we begin. Next slide, please.
Come on.
This emphasizes the point about uninsurance, and this is only among the non-elderly population. And you can see The numbers of uninsured decrease in 2014. That's because the Affordable Care Act went into force then. It was passed in 2010, but didn't take effect until 2014. And you can see in 2018, we're left with almost 28 million uninsured. Next slide. So let's look first at whether there have been any public policy driven modifications of all of those people who have private insurance, mainly through employers, but also through the marketplaces, the ACA. So the Family's First Coronavirus Response Act, that was the first big piece of legislation to go through Congress, did require all group and individual health insurance coverage to cover testing and diagnosis without cost sharing, without billing people. However, this act does not require private insurers to cover any treatment for the coronavirus. So people sometimes get confused, including the president himself in one press conference, and think that Congress has covered the cost of coronavirus treatment. And that is not true. What is covered by law now is testing and diagnosis, but not treatment. A few large private insurers have volunteered to cover treatment. Humana is one of them. And others have agreed to take some other measures, such as expanding telemedicine, relaxing prior approval requirements, and so on. So the point here is not that people with private insurance don't get any coverage of coronavirus treatment. It's that they will still be faced with deductibles and other cost sharing, including considerable hospital bills if they have any. So that was the federal level. States license and regulate private insurance plans that are offered in their jurisdiction. And some states have issued additional regulation for private insurance. And these involve different degrees of covering treatment. Only 3 states in the District of Columbia have obliged private insurers operating in their state to cover treatment and not leave people with bills. As far as I can tell, the House Democrats in Michigan have introduced a bill to mandate private health insurers cover treatment, but it does not seem to be moving forward. So privately insured members of the population get testing and diagnosis. They will get some coverage of treatment, but may be left with large bills, especially if they're hospitalized. Next slide. If we turn to the situation for those people who are publicly insured, starting with Medicaid, we know that most states have modified Medicaid to cover not only required testing, but also treatment. And Medicaid generally has very limited cost sharing. Now remember, quite a few states have not expanded Medicaid. This is only for people who are Medicaid eligible. Michigan is a state that has expanded Medicaid, and you may have heard that its attempt to attach additional work requirements have been ordered suspended by the federal district court. So those work requirements that were supposed to start in January are not active now. And on March 6th, Whitmer announced some of these measures to accommodate coronavirus. A bill is pending in the legislature to extend the Medicaid modification in Michigan to cover more than what we normally think of as healthcare, to cover medically necessary expenses for hand sanitizer, face masks, and quarantine or isolation. So people who have Medicaid, and that's a relatively large population in Michigan compared to some other states, have pretty robust coverage of costs. Next slide, please. So Medicare, again, is the federal health insurance for those mainly over 65 and with some specific illnesses and disabilities. Federal rules have expanded Medicare coverage for telehealth. And that seems to be one of the main things that has happened in the sphere of Medicare. There is no full coverage of coronavirus treatment costs for Medicare patients, even though Medicare covers a substantial proportion of hospitalization costs and Part B, other sorts of non-inpatient costs. Next slide. Then we are left with the problem of people who do not have any insurance, who don't have private insurance, either through employers or the marketplaces, who do not qualify for Medicaid. Perhaps they're in a non-expansion state or otherwise haven't applied, and do not have Medicare. So uninsurance, the lack of any insurance coverage has increased in the pandemic, mainly due to skyrocketing unemployment. So remember, a huge number of people have health insurance through their employer. Unemployment has reached record levels and is continuing to increase. When people lose their jobs, they lose their insurance. So the Trump administration decided not to expedite new applications through the ACA. However, people who lose insurance through job loss have a legal right to apply for private insurance through marketplaces in what's called a special enrollment period. And Medicaid, if they qualify, is always open, but in non-expansion states, it's almost impossible for an able-bodied person to qualify for Medicaid. So there are some options for the mass of people who are losing insurance through job loss, but they are not going to be easy to navigate, and some people will not have any reasonable options. Those people who are not uninsured because of job loss, but decided not to insure privately and not to apply for Medicaid also risk facing no insurance options, or now a very slow application process. And this matters a lot in many ways. So people who are not continuously insured generally lack primary care. And the current advice, if one is concerned about symptoms, is to call one's primary physician. And the primary care clinic is an important link to health in this pandemic. And people who don't have primary and linked specialist care generally have poorer management of chronic health conditions and therefore higher risks for COVID severity. Many of the uninsured work in jobs that may increase their risk of exposure to COVID. And the new paid sick leave doesn't reach, or family leave doesn't reach all of these workers. And someone asked the other day how COVID care in hospitals for the uninsured will be funded. This is a little bit unclear. There is some money in the third congressional piece of legislation, but it is really unclear how much will be going to hospitals and for what. So we see here that this is a problem also for hospitals, as well as for patients themselves. Next slide, please. So why does this problem of limited insurance and uninsurance matter in this epidemic? Many of the uninsured or underinsured are starting with poor health, and they're disconnected from the healthcare system, and poor health appears to increase COVID severity. Secondly, people don't consult their provider when it's medically warranted and may not know their own status or how to take precautions. Thirdly, people face very large economic burdens in this epidemic if they become sick, especially if they're hospitalized. Next slide, please. We also see the reopening and reinforcement of healthcare and health disparities. These disparities based on class and race are reflected in the COVID cases. And I think there'll be one more slide after this about that. The burden of no or costly access is not just a problem for the patient. Infectious disease is contagious, and we depend upon each other to protect our health. So the fact that some people are not linked to primary care or specialist care, or might face daunting bills and be reluctant to go in, is not simply a problem for the patient, but for all of us. And then we have the question of how hospitals are going to cover treatment costs of those who are uninsured and cannot pay. I think there might be one more slide.
Yep.
So this is just an illustration of something that we're increasingly hearing and talking about. In fact, Anthony Fauci made a very articulate statement about this, I think, yesterday, that what we are seeing in the pandemic are the pre-existing long-term health and healthcare disparities that characterize the US society and the healthcare system. So the high infection rate and severity in African-American populations are due partly to pre-existing health conditions and also to disparities in what goes on inside the healthcare system. In addition, it's likely that low-income people of color are doing essential lower wage jobs in healthcare, in-home caregiving, grocery and pharmacy and transportation services, and so are more exposed. They tend to be unable to stay home for financial reasons, and to go to work, they're more dependent on public transportation. So this problem of insurance coverage and access to the healthcare system is kind of revealing in a frightening way some pre-existing problems in our healthcare system, including healthcare disparities. I think that's the end of the slides.
Thank you, Peggy.
Oh, I am supposed to introduce Chris Douglas. Are we ready for that now?
If you don't mind, thank you.
Chris, where are you?
I'm here.
There you are. Hi.
Hi, Peggy.
So Chris Douglas, who is my near neighbor in our office suite, earned his PhD in economics from Michigan State University in 2007. He teaches a wide variety of economics courses to undergraduates and graduate students. His research interests include applied macroeconomics, energy economics, public finance, and sports economics. And he has had his research published in various peer-reviewed economics journals. He currently serves as co-editor of the Journal of Economic Insight and is the president-elect of the Missouri Valley Economics Association.
Let me try to share my screen here. Okay, is that working?
Yes.
All right, good deal. Let's start the slideshow here. Okay, so just a real quick summary about the economic impact of COVID-19, at least so far. The economic indicators are not good, to say the very least. In fact, they are Great Depression level bad. We've seen a stock market crash on par with what we saw during the onset of the Great Depression. Data on GDP, or gross domestic product, which is the value of all final goods and services produced in the US. Basically, the amount of stuff the economy produced is not available yet, but that's likely Great Depression bad too. Data on the unemployment rate isn't available yet for the month of April. Unemployment rate data always comes out the first Friday of the following month, so we'll know April's unemployment rate first Friday of May. That's likely going to be pretty close to being Great Depression bad. So that's all bad news, of course, but just because we're seeing Great Depression levels of economic indicators doesn't mean that we're rolling into another Great Depression. In fact, I think we're avoiding a Great Depression, at least right now. The longer term economic recovery depends on how quickly COVID-19 is mitigated and then how confident people are to get back to their daily routines once it is. So the one piece of data we have right now are initial claims for unemployment insurance. That's released weekly. The third week of March, we saw 3.3 million people file for unemployment. In the fourth week in March, 6.7 million people filed for unemployment. First week in April, this was just released today, 6.6 million people filed for unemployment. So far, 17 million people have filed for unemployment, and there's about 152 million people in the workforce. So that means that roughly 11% of the workforce has filed for unemployment so far. In a typical week, about 200,000 people file for unemployment because, even when the economy is good, relatively speaking, like it was before COVID, people still lose their jobs. So you're having 6.7 million people file for unemployment. That's about 32 times higher than what's typically the case in a normal week. That probably understates things too, because there's so many reports of websites crashing, phone lines being jammed, that probably more people wanted to file for unemployment but were unable to get through. To put that in some more perspective, the record level of unemployment filings happened during the Great Recession about 10 years ago. Third week in March 2009, 661,000 people filed for unemployment. So having 6.7 million people file for unemployment first week in April, that's 10 times higher than the record. In the fourth week in March, that was 10 times higher than the record as well. 385,000 people filed for unemployment in Michigan first week in April. That's almost 2 times higher than what's usually the case for the entire country. Stock market, Great Depression versus now. During Black Monday and Black Tuesday, at the onset of the Great Depression, which is October 28 and 29, 1929, the stock market lost 23% of its value. During the month of February to March 18, 2020, the stock market lost 32% of its value. Although it's recovered, not quite half, maybe roughly half of what it's lost. Comparing the stock market now to the Great Depression is a bit apples and oranges because I'm comparing 2 days during the Great Depression versus a month now. And the stock market lost much more than 23% of its value as the Great Depression dragged on. It's just that the decline we saw last month in the stock market was very volatile, where we would have days where the stock market would decline 2,000, 2,500 points, then rally by 1,500 points or so. So it's just not really clear what 2-day period I should use to compare the stock market decline during COVID to the Great Depression. The point is just that we've seen comparable market declines now compared to back then. GDP and unemployment, Great Depression versus now. GDP contraction means how much the economic output shrink by. Economic output shrank by just over 26% between 1929 and 1933 during the Great Depression, with unemployment peaking at nearly 26% in May 1933. We don't have data on this yet for the current recession, but given current unemployment claim filings, it's projected that unemployment is going to hit 15%, at least by June, which means that GDP, or economic output, would contract by about 30% or so in the second quarter 2020. Unemployment is measured monthly, GDP is measured every quarter. A 30% contraction in GDP for the second quarter 2020, that would be on par with the Wall Street Journal's finding that currently, right now, about 24% of the economy is idled. This is also a bit of an apples to oranges comparison because it took 4 years during the Great Depression for the economy to contract by 26% and for the unemployment rate to hit 26%. Whereas with the COVID-19 shutdown, the unemployment rate's going to do that maybe in a month or two, and the economy is going to contract by 30% in a quarter, not 4 years. So it is quite remarkable that what took 4 years to happen during the Great Depression, it was happening in like 4 weeks right now. So that's all bad news, of course, but I don't think that means that we're going to have another Great Depression. Right now, it seems like the Federal Reserve and the CARES Act, which is the Corona Aid, Relief, and Employment Stimulus. I guess every piece of legislation has to have a catchy acronym coming out of Congress. That's the $2 trillion stimulus that was passed by the Congress and signed by the president. The Federal Reserve and that $2 trillion stimulus, seemed to be preventing a Great Depression. The reason why we had a Great Depression is because we took what should have been a mild recession and made a bunch of policy mistakes and prolonged it into a big depression. So for instance, during the Great Depression, the Federal Reserve failed to act as a lender of last resort to banks and instead stood by and let a third of the banks of the US fail, which resulted in a massive financial crisis. The Federal Reserve is being very active right now and being a lender of last resort, which is preventing that from happening. The stimulus that was passed last week, it seems to be having its problems, especially with small business lending. But the $1,200 that lots of people are going to get, coupled with unemployment insurance that fully replaces lost wages, will help people pay their bills and helps businesses keep people on payroll. So that'll prevent the breadlines that we're seeing during the Great Depression. It prevents people from living in what were called Hoovervilles, which are basically cardboard shacks people lived in after they lost their house where they couldn't pay their mortgage. Named after President Hoover, who people blame for the Great Depression, unfairly in my view, but life's unfair, so that's the term that stuck. Because people can continue making the mortgage payments, they won't lose their homes. And because people will make their mortgage payments, that means banks and lenders will get repaid for the mortgages that they issued, which means that they can repay depositors and people who supplied the funds for these loans, which means that hopefully we could avoid a financial crisis. So the really key thing to avoid a severe recession or a depression is to avoid a financial crisis. We didn't do that during the Great Depression. During 2008 and 2009, we had a big financial crisis. That's why the recession was so deep and the recovery was so slow. So if we can avoid that again, we should see a better outcome. So this is all optimistic, but if you think about where the $2 trillion came from in order to pay for the stimulus, that $2 trillion was simply printed. And you can't print money forever without inflation kicking in. If production becomes idled for a long period of time, fewer final goods and services get produced. So repeatedly printing $2 trillion worth of new money will be the proverbial too much money chasing too few goods, which is inflationary. If that happens, we get the worst of both worlds because we would end up with stagnation, which is economic stagnation, or we would get stagflation, I'm sorry. Which is what we saw in the 1970s, where we had economic stagnation plus inflation. It's just the stagnation would be a lot bigger than what we saw in the 1970s. Also, during the Great Depression, there was lots of fiscal policy mistakes that were made that we don't have time to get into, but we seem to be avoiding those, at least for the moment, which is also a reason to be optimistic that we're not looking at another Great Depression. So to conclude, what's the economic recovery look like? I think the best case scenario, and maybe the most likely scenario, is what's called a V-shaped recovery. V-shaped recovery means there's a quick contraction. That's the first part of the V, and we've seen that already. But there's also a quick recovery, which is the second part of the V. And I think this is likely to happen if COVID is short-lived. Projections right now have COVID dying out right around June 1st. And if that holds and there's no second wave, or at least the second wave could be better mitigated through better testing and more focused rather than blanket lockdowns, and then ideally there's a new vaccine developed in 12 to 18 months, I think the odds for a V-shaped recovery are good. As I mentioned earlier, this really hinges on people's confidence that they could safely return to their daily routines, but I think the odds of that are pretty good too. I constantly read reports of people not social distancing, but the silver lining to those reports is that suggests that, once the virus is mitigated, people will be eager to get back on with their lives. Most businesses will probably reopen, probably rehire their workers. There probably are some businesses that were teetering before the crisis, businesses like various brick and mortar retail outlets, businesses like shopping malls, that probably won't reopen. But I think most profitable businesses, or at least profitable ones before the crisis, will reopen. I think the stock market partially recovers. We've seen a partial recovery from the high 18,000s to around 23,000. But I don't think we get all the way back to 29,000 that we saw before the crisis. just because there are going to be parts of the economy that are slow to recover, which will preclude a complete market recovery. Forecasts have the Dow getting up to about 27,000 by the end of the year, maybe to 2021. And I think that's pretty reasonable. I think that you're going to see GDP and total employment start to grow in the third and fourth quarters of 2020, where you might be talking, in the most likely case, assuming a V-shaped recovery and mitigation by June 1st, somewhere around 6% economic growth in the third and fourth quarters. Maybe take the unemployment rate down from 15% to the single digits, and then see a more robust recovery in 2021, where forecasts have the economy growing by about 5% in 2021, which would kind of get us back to where we were before the crisis hit. I think global trade and international travel are going to be slow to recover. It's going to be a while, maybe a year, give or take, before people are willing or able to hop on an international flight. Maybe people are confident flying domestic, staying in domestic hotels. But the real concern, I think, is going to be that if you hop on an international flight and there's another flare-up, are you going to be stuck overseas or not? And I think you're going to see nationalistic trends, people questioning globalization, those trends to accelerate after the crisis. Particularly, I think people are going to start questioning the US's relationship with China, especially with the Chinese government covering up the virus on the onset, when quick action could have probably prevented all the problems we're seeing now from happening. I think other trouble spots for the economy are going to be state and local governments. They're constitutionally required to balance their budget. Running massive budget deficits, that's a privilege only the federal government gives itself. So state and local governments are going to see a tax revenue hit due to the economic slowdown. And it's hard to know exactly how big that hit will be. But there's estimates out there that say that Michigan will take a $2 to $4 billion hit this year, then again next year. And Michigan's general fund budget's only $10 billion. So $2 billion out of a $10 billion general fund budget, that's a big chunk. The state spent the better part of last year trying to find $2 billion to fix the roads and weren't able to. So how are they going to find $2 billion to plug $2 billion worth of lost tax revenue? Probably not very easily. State and local governments will get $175 billion from the stimulus. That'll plug some holes, but it's hard to know how many. So ideally, we get out of this with a quick economic recovery at the end of 2020, and just have the federal government be another $2 trillion or so in the hole due to the stimulus. Things get a lot messier, economically speaking, if COVID-19 is longer lived, if the shutdown persists past the end of May, or if we have an outbreak that flares up in the fall, the winter, and we're not any better mitigating it then as we are now. But I think, and I hope, that's pretty unlikely. So that's all I've got. If we have time for questions, I'd be happy to take any questions people have. So
Thank you so much, Chris. I thank you to all the speakers. And if you don't mind, I know it's like 5 minutes to 7, but we can hang around a little longer if you don't mind. I do have already 2 questions or comments that came in via chat while we were all speaking. So I'd like to give them a chance to talk. So the first one is Dr. Laparose.
Hi, everyone. I just wanted to make a quick comment about health disparities. I think in the media, as well as today, we're talking about disparities in terms of black and white, and it's much more complex than that. Also calling attention to the word disparities versus inequities. So disparities just mean that there's differences between 2 groups. But I think what we're talking about are really health inequities and how populations of color have unequal access to healthcare and quality of care and other resources that would permit us to live healthy lives and a good quality of life. So what I wanted to talk about, my area of research is in Latinx health disparities, and the Latino community is experiencing these disparities at an exasperated rate, because in addition to these, markers of social economic status, they're also having language barriers, but also things tied to citizenship. And so that, again, impacts access to services, information to make informed health decisions, not being familiar with how to navigate our health systems and other social services. So there's multiple layers to understanding how health inequities operate besides just simply race and social economic status. There's, language and citizenship, and that's basically what I wanted to say. Thanks.
Thank you, Dr. Al. So I know there are a lot of this, so we were supposed to talk for 10 or 15 minutes, but we could probably go on for hours about each one of these things. Hiba did have a question for Dr. Amini. So if you want to go ahead, Hiba.
Yes, first of all, it was a pleasure attending this Zoom conference. Every single speaker had some awesome, wonderful information to share, and I've definitely learned a lot from all the speakers. So I just wanted to ask Dr. Riza if he can talk a little bit more about the permanent cardiovascular damage that we're seeing following COVID infection and treatment. Specifically, whether this is related to a pre-existing cardiovascular condition, or whether this is also common in people who may not have otherwise been diagnosed with cardiovascular disease.
Thank you. That's a great question. We are still learning about the disease and the consequences and side effects of diseases on different organs. But about the heart disease and the damages to heart, it can affect everyone. So it's very interesting that people with pre-existing heart disease, they have a lower risk of death or mortality compared to those without pre-existing heart disease. So if the heart disease, if the virus damages the heart tissue, there is a high risk of death. But about the permanent damages, there are some cases recovered fully after the infection was eradicated and patient recovered, but there are still some cases, reports that cases people suffering from heart damage after the recovery. So we are still collecting data. We don't have enough information to have a conclusion, but we know that the virus can affect the heart tissue. Some of them can stay with the patient even for 2 or 3 months after this disease. I hope it helps.
Yes, so really the effect or the damage is temporary, not permanent, as we've been hearing?
There are some cases with temporary damages and some cases that they have the damage even for 2 or 3 months. But we don't know, maybe after 1 year, they can recover slowly.
I think we're all still learning about this. Thank you very much.
Of course.
So I don't see any more questions within the chat, but if anybody has any questions, I think there's a raise hand function here. So maybe there isn't. There was yesterday.
I'm raising my hand, Michelle.
Go ahead, Michael.
It's a question for Stephen and perhaps for you. I looked at the cruise ship data about survivability of the virus on surfaces, and I wasn't clear from the study. Well, first, what's the current thinking on how long this is survivable in the hospital setting, which is my concern. Viral particles on the surface of a cruise ship does not mean that this is indeed a surface that you can get infected from the virus. But do you have any recent data on that topic?
So I'll answer that. I don't know if Stephen knows anything about in the hospital. What I read wasn't hospital. They were peer-reviewed articles, but not done in hospitals. New England Journal of Medicine had one recently. And that article, so different articles, of course, have different lengths of time, seem to think that the longest it would last is on plastic surfaces or metal surfaces. So they were checking different surfaces. and they were talking about 4 days that they could actually detect, the particles. But like you said, that does not mean that those particles can infect you. I don't think they really have a good handle on that. And I think, they were doing that in whatever conditions they were doing it. Now, there's the possibility if I was to replicate that study and it was hotter in my room or colder or more humidity or less humidity or whatnot, that could change. So I think that's part of why we're seeing like conflicting information on that. It really depends on a lot of different variables. It may be even on, the particular viral particles that we're using. Who did they come from? Were they already weakened? I can think of a million things. So the last thing that I read was that, that after 72 hours, you should probably be, safe. But I still wipe everything down when it comes to my house, just because it's not going to hurt me to wipe things down, right? It's not like there's really any bad side effects, except maybe becoming a little neurotic. But, it's not on the same scale as taking a medication that I might have very bad side effects to prevent it. So if you're looking to know how long, I don't think we know how long. I think it depends on the conditions and the actual, where did we get the virus from? Has it already been weakened? But if you're looking for advice, I would write things down just because, hey, it's not going to hurt. And I don't know if Steven started anything about the hospital. I'll let you talk.
Last I heard was kind of the same thing. The CDC guidelines is like 24 hours for softer surfaces and then the 72 for hard surfaces like metal and stuff. So I imagine if it's been 3 or 4 days, it's probably okay. But that's like Dr. Sally said, if you can wipe it off, please do so.
Thank you.
I know for our rooms, after the patient, if they've passed away, usually they have to wait between like 32 and 70 minutes before they'll even go in and clean it or do anything with the body. So that's a precaution we're taking, at least for the air.
Thank you, Stephen. We have another question. So it's from Brenda. Do you want to ask Brenda? Brenda, where are you?
I'm here. Dr. Khan answered my question.
Okay.
So my question was that if there is thoughts that there would be a risk of mosquitoes transmitting the virus now with spring and the warm weather, because I know we're getting a lot of mosquitoes in our backyard. But she said the WHO says that the disease is not carried by mosquitoes.
We don't know still. There are some studies going on about the mosquitoes. We know some mosquitoes can transfer some other viral diseases like West Nile, but we still don't know for sure.
Thank you.
You're welcome.
Michelle, I have a question.
Yeah, so I have a few others, Doda, and then I'll call on you. They've been writing them in the chat, so they've been waiting.
Okay.
Jack Kelly asked, I'm just going to read this, Jack, if we think that summer fairs and carnivals will make a return this year. I don't know. It depends on how quickly this resolves itself and how many people are still getting sick. So I don't know if people are going to really want to go outside or not yet. I don't know if any of the other presenters would like to speak to that. Heba has a question for Chris.
Okay, actually, before I ask it, I just wanted to share that the coronavirus may last up to 2 years in below freezing temperature. I think there was an earlier question about the cruise ship. So if there was a virus in one of their freezers, it may last up to 2 years. Okay, so my question to Chris, just wanted to share that my husband has a small business and he's been paying his employees even though, there is no business right now. Giving them some work that they can work from home or in the office, but by themselves, like without anybody around them. So now they're telling him they don't want him to pay them the regular salaries. They would rather take unemployment. Are you seeing that, how would this play into the bigger picture where people can, employers still want to employ their employees, but employees preferring to collect unemployment versus actually being paid for their, regular salaries. And there's also the forgiveness loan program, but the question mark is, are they all gonna be honored? Or do these employers who have small businesses who choose to continue to support their employees, honestly, for humanitarian reasons, eventually could they also get a slap on the hand and not receive those forgiveness loans that are promised?
Yeah, those are all good questions. So for the unemployment case, why do you think your husband's employees would prefer to take unemployment versus earning a wage? Because unemployment insurance is not supposed to be higher than your wage. Usually it's lower.
They prefer to not have to work and just stay with their children. That's what they're telling them. They will take a pay cut and will just stay home, not have to worry about anything, just stay with our kids.
Oh, I see. Yeah, that's an issue. I think the thinking of the Congress was that if they do full replacement of wages with unemployment benefits, that would allow people to continue paying their bills who were involuntarily laid off. But that has the unintended consequence of there might be people who voluntarily choose to not work in order to collect unemployment. Although I'm not an expert on unemployment in terms of the mechanics, but my understanding is that you had to be fired in order to collect unemployment, that if you voluntarily quit your job, you weren't eligible for unemployment. Is that not the case?
I think they're functioning under several premises. One is like kids are home and they all need to do online schooling. So parents can't work from home. They need to dedicate the energy to teaching their kids who are now studying home, online. And the other thing is, I think they think that if they, quit themselves, if they say, no, I'd rather have unemployment than work, they still think that they are collecting unemployment. I didn't know that they have to be fired for them to do this. And I'm not sure that they knew. But this is just one example of one small business. But there are a lot of people that are also choosing to take that route, thinking that unemployment will be a better option at this point than continuing to work.
Yeah, so I think a trap workers fall into is they quit their job thinking they're eligible for unemployment, and then they find out the hard way that that's not the case. So that might be happening there. I think another problem is potentially that if you have certain sectors of the economy shrinking, like bars, restaurants, small businesses, retail, but you have other sectors of the economy growing, like grocery stores, other essential services who need to hire people, maybe they're going to have a tough time finding people if unemployment becomes a much more viable option, coupled with the fact that people have to stay home and watch their kids because schools are canceled for the year. So you might run into places like grocery stores and similar businesses that have a tough time attracting workers due to those constraints. The small business lending, that seems like it's been kind of a mess as it's been rolling out. It seems like it's a cumbersome process. Banks don't really want to get involved because there's not much interest to be earned with all the government paperwork they have to go through. And it seems like Congress didn't appropriate enough money for the program. So if that program kind of falls apart, I think that's going to slow down the economic recovery if otherwise viable businesses go bankrupt during the shutdown.
Yeah, thank you, Chris, and thank you to all the speakers. I do have to log out now, but I really appreciate everybody's input.
We have two more questions. One from Dauda Abubakar.
Yes, can you hear me?
Yes.
Yeah, thank you, Michelle, and the other panelists, Peggy, Chris, Amini, and Stephen. I think this is a very good conversation that we needed to have in a community like ours. My question is to Peggy and then to Chris. First is to Peggy. I was wondering that from your presentation, what does it tell us about the U.S. Healthcare system? The way that a state or a country addresses the healthcare needs of its citizens. That is one question. And to Chris, it seems to me that the last part of your presentation, if I get it correctly, you are optimistic that we can bend the curve and get out of this pandemic, and then life will get back to normal. If I get correctly what your last slide about the recovery is saying, in other words, that the economy will begin to pick up again, people will get back to work, and then life will come back to normal. But I would think that wouldn't that depend on whether everybody does what is required? If you look at what is going on across the country now, not every state, for instance, has a stay-home order to its citizens. And this is a virus that we can't see, we can't smell, we can't know how it is working and spreading effectively. So do you think that recovery is still feasible by the end of the year as you are projecting? So those are my questions.
So in response to your question about what does this say about our healthcare system, I myself would say it is shining a strong and deadly light on its inadequacy and the lack of universality, the lack of coordination. Many people would like to argue that this is something that may push forward the debate about what to do after the ACA, what kinds of reforms, whether that is expanding on the ACA or moving quickly, which is about 4 years, to Medicare for all. Other people are going to want to isolate this and say this is only a crisis and it tells us nothing about the normal operation of the healthcare system. So I think that would be my main response, that I think that it does shed a light on some of these terrible gaps and the complexity and lack of coordination.
Right. Yeah, thank you.
I guess my optimism stems from projections like the one of the University of Washington that shows that by June 1st, the virus should be relatively died out. According to the model that was updated on the 8th, which I guess was yesterday, Michigan is 2 days past peak resource use. And it seems like the statistics coming in are well below the dire predictions that were made last month, even though there's, I think, 8 states who are at social distancing right now. Those seem like pretty rural states. I think South Dakota's one, and they don't seem to be hot spots yet. So my optimism is that we'll at least buy some time in the summer. Maybe the virus will retreat in part due to the heat of the humidity, and that we could kind of gear up just in case it comes back in the late fall, the winter, so we could be better prepared then. So we could do better testing and tracing. We don't have to lock down entire states or entire parts of the country if we have a flare up in one particular geographical area. So that even if we do have a second wave, the economic devastation from that second wave won't be as great as what we're experiencing right now.
Right. Yeah. Okay. Yep. Thanks.
Well, thank you. We do have one more question. I know we're already over time, but Chandramuki's been waiting patiently to ask a question. So go ahead, Chandra. Unmute.
Hello, hello everyone. I got sort of my answer, but I would like to ask again. Because people are getting impatient and we don't know when the vaccines will come out and we don't know about the medications, but maximum till what time this lockdown can be endured?
Who's your question to?
My question too is about, we know that this virus...
Who are you asking that question to?
Oh, I don't know, it's in general, whoever...
So how long can it be endured? Well, you know, right now it's as long as it takes, right? So I don't know how long people can endure it, right? I don't know how long society will be able to endure it, but it would do no good to stop the lockdown and let everybody go and just go about their business all of a sudden and for the curve to go right back up. So, I mean, there's no definitive, so modeling, it's, you know, you've seen the models of diseases. Some say, you know, oh, in May, some say in June. That changes every day depending on what we do. But it's not going to be very helpful for, I mean, it'd be kind of like we did this all for nothing if we go too early and start about our normal lives and everything goes back up again. So, I mean, my answer, I know it's not a good answer, but it's the only one I have is as long as it takes.
Okay.
Can I reinforce your answer?
Sure.
So what I've been hearing and reading is we cannot make this decision based upon our impatience or our anxiety or economic calculations, that we need to do it based on public health and biomedical data. And the data that people are offering is, first, we need to see a sharp decline in the number of cases for 2 to 3 weeks nationally. And I've heard British scientists say under 50 new cases a day. So that's diagnosed cases. We need to see a decline in hospitalization and a decline in deaths. And to get back to Dr. Sali's comment, we might want to look at the R0 number to see if that is under 1. Secondly, people are saying we cannot open up again until we have a robust testing architecture, meaning we can test for the virus with contact tracing and maybe start testing for antibodies. Third, we need a healthcare system that has spare ICU beds, adequate equipment, and robust, healthy staff. In other words, when the hospitals continue to be challenged by the number of cases is not time. And that was part of the idea of flattening the curve in the first place. It was to make sure that hospitals were not over capacity. And finally, people are saying we need effective therapeutic interventions. So we need to buy time so that we have some treatment and then possibly prevention, though the vaccination is a long way away. And then there is a lot of debate about whether it's possible to move gradually with variation across social sectors. So I've heard one comment that since children don't seem to be so prone, one thing that might be possible is to move carefully to opening schools before other things are open. And then there's the issue of place that I think Chris also alluded to, that where we see better numbers, better data, it might be possible to release some of the measures before other places that are still hotspots.
So Chandramukhi, remember when we were talking about flattening the curve, what that does?
Mm-hmm.
So a hospital will be better off getting 10 patients for 10 different days than 100 patients in one day. Right? So when we flatten the curve, we kind of, I know it's counterintuitive, but you kind of make it longer, right? But this way we're not overwhelming all the hospital capacity and all that kind of thing. So there's a lot that plays into that. I wish I could give you like a definitive date and say like on May 13th, you know, what happened, but unfortunately not.
But that was a beautiful perspective. I got so many points.
I'd like to thank the panelists for agreeing to do this at the very last minute. I know I met Peggy back in February, right before this whole thing started happening, and I wrote to her and she was like, sure, I'll do it, probably within an hour. Chris, Mark Kylan found him for me within maybe 2 hours. Dr. Meany, of course, I just assumed he would be there. And Stephen especially, because Stephen has been working overnights in the ICU, and he's been keeping up with his schoolwork and worried about his capstone and his internship, and he still came to talk to everyone. So I'd like, everyone has left, but please give a hand to Stephen, especially for showing up. Thank you, Stephen. I'd like to do this again, maybe in a week or two. We can get another panel. If you want to, you can email me with topics or speakers that you think might be great. But Gina, she knows how to clap on Zoom. Thank you for everyone for attending. It's been great talking to you and seeing some of you, because I kind of miss actually seeing people and talking to them and not just on the phone or typing them. So with that, thank you for staying, panelists. Have a great night.
Yeah, bye-bye.
Thank you, everyone.
Thank you.
Thank you so much.
Bye-bye.
Bye.
Bye-bye, everyone. Bye, Stephen. Thank you.
Bye.
Bye. Everyone's going little by little. I could see. Bleep, 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 bleep.
Bye, Peggy.
Good job, Michelle and everyone.
Thank you, Alon. Thank you for coming.
Oh, it was excellent. Thank you.